Hello, my name is Annegret Dahlmann-Noor. I'm a Professor of Pediatric Ophthalmology at University College London and Moorfields Eye Hospital and the NIHR Moorfields Biomedical Research Centre. Today I would like to talk about the WSPOS Consensus Statement on myopia management and specifically want to go over management options in Europe. We now have many options available, but not all of them are available and affordable and accessible to all the children in Europe. I think it is important to take into consideration the child's lifestyle and preferences. So obviously, as ophthalmic practitioners, we also look at the previous ophthalmic history. So that includes measurements of the refraction, going back over the history of the refractive development over the past couple of years, and we usually measure axial length. However, I also feel it is very important to take into consideration the family history. If they are now low myopes, I ask about the child's medical history, so other conditions that might be driving the myopia. And once I'm happy that it is indeed simple myopia, I ask about lifestyle, how much time the child can spend outdoors, their preferred activities, what other activities they do outside of school in terms of education and hobbies. I discuss the options with the family because I am utterly convinced that the most successful treatment is the one that the child will use. So it depends hugely on their lifestyle and on their experience, really, whether they would like to go for the special myopia control glasses or contact lenses or for the Atropine. In my practice, there are very few children who opt for Atropine as a first-line management. Children with myopia tend to wear glasses, so they just want to switch from the standard single vision glasses to myopia control glasses. So across Europe, we have got a very variable landscape of availability of all of these treatments. Up to this date, the landscape has therefore been dominated by compounding low concentration atropine either at local hospital pharmacies or at national hospital pharmacies. The challenges with that are mainly to do with quality assurance. So atropine is very difficult to get into solution and to keep into solution. In terms of preparation, if you just use the common ingredients, let's say, and use normal saline as a carrier, there is an additional problem with the pH. So you have to work with a relatively low pH to keep it in solution, and that might, of course, then not be well tolerated. And children and young people might complain that the preparation of formulation stings. So replacing that going forward by a commercial product that can be produced at scale with quality assurance bundled in will be a great step forward. We have got a very variable level of awareness across Europe. In the general population, the awareness of myopia being a condition that can lead to sight-threatening complications in later life is quite low. But particularly in urban areas where we have migrant populations who have come to Europe from South Asia and East Asia, the awareness is quite high. There is an increased awareness that it is now possible to slow progression in children and young people if we start early enough and have enough treatment options to tailor a treatment to the individual needs of the child. So in the United Kingdom, for example, there are 15,000 optometrists and they provide the primary eye care for children. So the more optometrists take up myopia management and offer myopia management products to their clients, the higher the awareness will be. We have known for quite a while that the onset of myopia can be delayed if children spend plenty of time outside. The overall recommendation is about 1.5 hours to 2 hours a day. So all the treatment options that we now have work better when children also have an eye-healthy lifestyle. And that includes spending time outdoors and not spending too much time indoors and on near-work activities. it's important to be aware that it is really the light that matters and not whether the sky is overcast or whether it is raining. The light outdoors still has a multiple level of luminance or brightness compared with light indoors. So on an overcast day or when you're under a tree, you still get more bright light compared with time that you spend indoors. In my experience, parents want to do the best for their child, and they will make resources available wherever possible. So I usually do not have a hard time to convince parents. On the other side, I feel that we have a responsibility, as I said before, not to scare parents and to reassure those who cannot afford those treatment options that taking the child for an eye test every year and keeping the prescription up to date with single vision glasses or contact lenses I think it is up to all of us adults around the children and young people to spread the word that there are now treatments, because children and young people themselves often feel anxious about myopia progression, not because of the late complications, but because they become more and more dependent on the glasses. So for me, spreading the word and raising awareness and providing education and support is the biggest take-home message from this consensus statement.